gonna let you guys get started, and I will see you during the other Q&A portion where we go over the presentation.
All right.
Thanks, Medina.
Welcome.
All right. So you've met Rob. Rob is a dear friend of mine. We're both coming to denture making from perfect opposites. You know, Rob's a longtime dental technician. I've been doing removable prosthetics for decades, and so between the two of us, I think we've both found a lot of interest in these new techniques that are coming out in the last couple of years. The work that we're going to do here is really inspired by the products from Dentsply Sirona and the technology from Carbon. If you don't know Carbon, it's a very high-end Silicon Valley 3D printing company, and between the two of them, the materials from Sirona, Dentsply Sirona, and the technology from Carbon is going to really be the basis for what we're going to be making here. We decided to call this a practical digital fabricated removable denture technique, and the reason why it's practical is this is something you can take home tomorrow or Monday and really start using to make a denture, to make a digital denture. So we're going to give you a specific technique. I think Rob would agree is that you don't need to do this technique to be digital, but this is something that I think is a great start and something that will really inspire you to even go farther if you need to. But so we're going to show you that. Now, I mean, I guess the question is what was wrong with what we were doing before? The technique that I learned, that my dad learned, that whoever's in dental school right this second learned, really came from the generation of the early 50s. This is Carl Boucher on the left and Muller Devan on the right. And they were the people that really said, make a preliminary impression, make a custom tray. The whole 5-appointment technique that we use today and that's trained in dental schools came from these people. And, you know, it does produce a great denture. This is a denture I made out of HIPAA, Rob. Oh, and yeah. It's, but it's, you know, the question of what's wrong with it, it was as good as I could do. This is probably the epitome of the dentures I made analog, but it was interesting. I think that digital can take us farther and solve some of the problems that are inherent in this denture. The need for 4 to 5 visits is a big one. I mean, it costs us quite a bit to run a practice, and the idea that you could have to take 4 to 5, maybe even more appointments to make a denture, and then only be able to charge whatever your community allows. I think you realize quickly that you can't really make a lot of money making a denture if you don't figure out ways to make it faster. So that's one big thing. Rob, what do you think about the fit? I mean, there was a lack of intimate fit to denture bases.
Right. I mean, it's been proven through studies, clinical studies, that, you know, I mean, the fit, you know, was compromised because of distortion during polymerization process of compression molding, and not so much as injection, but more dealing with compression molding. Mm-hmm. But also how the person's processing. You know, as far as the, you know, I just want to comment on patient visits, you know, linear versus branching. You know,
right.
With and with higher and different, you know, needs and desires, it is important to have more patient appointments and develop more of a branching workflow rather than a linear workflow, mm-hmm. as with the 4 to 5.
Yeah, I think what we're going to show you here is linear for sure, and because it's extremely efficient. But maybe in a future webinar we could talk about how to take it different directions, how to work with maybe more difficult patients. But the 4 to 5 visit appointment really for an average patient in a general dentistry office needs to be a thing of the past. And I think we're going to show you how to do it. Again, that would strike to Rob is the idea that it's very difficult to duplicate a denture with analog. With digital, it isn't.
It's impossible. I mean, people say duplicate on a prescription, duplicate this denture. You can get maybe 90%, 95% maybe, but you cannot get it exact. Replicate exact. But now in the digital world, a digital workflow, you can absolutely duplicate and replicate that existing denture.
Well, you know, and there's
over and over.
There's a lot of advantages there. I offer a second denture, a spare denture to everybody now. I'm 100% digital. I'm all the way, and I offer them a second denture at a very decreased cost. A lot of them get them, and so it's a way of maybe opening up the denture market a little bit. There's a lot of creative ways just because you can duplicate it. Denture making is a craft. Now that's very true. I don't consider myself. I consider myself a craftsperson, not a scientist. I mean, making a denture is a hand thing, and it takes a while to learn it. I mean, Rob, after 40, 50 years, is still learning. I'm still learning. So it's a craft, and schools don't really have time to teach the dental student how to make it. So that all goes together. You don't have good training, and you don't have enough time to get out of dental school running because it takes a while to learn.
Right. And you never stop learning. I think that's the most important thing to take. You know, never stop learning. Always every day try to learn something new. But I absolutely agree. It takes time to, really understand all the variables involved and how to recognize the variables, in different situations. And then understanding what to instinctively do and how to treatment plan the case. But yeah, it does take a long time, and it is unfortunate that in most universities this time is not spent on in education at undergraduate.
Well, and I think that plays to, I mean, I don't know how many new dentists are in the audience, but you get out of dental school and I know you don't know how to make a denture. You pretend you do, but you don't. And it takes a while. And unfortunately, there's so many denture patients out there that you could serve, that you could feed your family serving, that, the old analog way was just too hard. Digital's easier, at least the thing I'm going to show you now. And it really will build up your confidence. How about fewer technicians? Is that still true? Would you agree with that or no?
No, absolutely. I mean, it started back in the 90s, to be honest with you. And that's when I used to have a full service lab in the 90s. And I saw that there were very, very few technicians going to removable. I started reading literature by Ted Jacobson, and Tom McGarry wrote some articles about the future and talking about the need, for technicians and removal prosthodontics, and so that's when I started devoting more and more of my time into removable. But since now, what we're seeing, unfortunately, through this COVID, culture that we've all gone through, that we're in the middle of a huge consolidation of dental laboratories. A lot of majority of labs that did removable were, technicians that, probably were in their 60s and older that own the lab. Many laboratory technicians have decided to close down or sell out, go out of business, unfortunately. But and then years ago, there used to be a lot of training facilities. When I was educated in the Army, we had the Army, Air Force training, Navy. I think we had around 60 schools, in the United States, and now we're down to, I don't know, probably around 13 or something like that.
Yeah.
So very, very few training, well-trained removal technicians, and unfortunately, that's how it is. But we hope, hopefully we can help change that, through different types of programs like this.
Well, I think there's a lot of enthusiasm for new enthusiasm from technicians I can feel here in Albuquerque because of digital. If it's familiar to them. The last one, this traditional materials can't withstand stresses of denture-based denture or implant-based dentures. That's true. The newer dentures that we're going to show you are much, much stronger, and they have less chance of fracturing. So why digital? Time. That's the big thing. We alluded to it. I'm going to show you a technique that takes 3 30-minute appointments to do, not 5-hour appointments. 3 30-minute appointments. And I'm going to tell you right now, I don't even appoint adjustments anymore. These dentures fit so well, I have the patients call me if they need to call me, and they don't call me. They fit so well. So we're talking really 3 30-minute appointments to get through the denture. And at $5 to $7 a minute, probably more in California, $10 a minute probably to run. I mean, if you could save 2 appointments, 3 appointments, 4 appointments, that's going to add up. Now, fit. This is a key. This is the reason to do CAD/CAM. If anything else, to do a printed denture, it's fit. Everybody thinks a denture stays in with suction. It doesn't. There's no suction underneath it. I mean, if your denture's sucked up into your palate, everybody would have like a hickey on their palate because it was just drawing blood out. It's not up by suction. It's up by with 2 factors: cohesion and adhesion. Cohesion is the natural attraction of molecules of the same material to each other. In this case, the water and saliva. If we have a saliva interface between the base of the denture and the tissue, that cohesion, that the water trapped in there will be drawn to get to itself. Just like on the end of a pine forest, you've got a little ball of water on the end. The reason why it's round is that the molecules are being attracted to itself. So that's cohesion. Now, adhesion is the idea that those water molecules will bond to the base and to the tissue. So if you have adhesion and cohesion acting, just like on the adhesion here is actually drawing that water up to the pine needle. If you have that in the denture, with a small space between the tissue and denture, that adhesion and cohesion holds that denture in. And CAD/CAM dentures have extremely good approximation and fit. I mean, here's the example. You take 2 pieces of glass and you take that suction cup that I had, put it on the top, pull the pieces apart. They part pretty easily, but you put water between them. The adhesive and cohesive forces are going to hold those together extremely strongly. And that's what you're seeing here. I mean, that's a pretty strong bond. You really have to tug on it to get it to pop. Now, those are 2 rigid pieces of tissue. If you have this represents the gums, which is not quite as rigid. If you have water between the denture and the tissues, you still have a good bond. But if any air gets around the edge of it, it's going to pop it. That's why you have a good seal, why we talk about seal. So there we go. This is an example of comparing a CAD/CAM base. Why don't you talk about this, Rob? Explain it to him. This means a lot.
So looking at the pack and press space, you can see where, the white, and compared to the green. Green is where you have more of an intimate fit. Of course, we have a 1-to-1 ratio, it fit. Whereas we have pack and press or compression molding, it's not a true 1-to-1 because of the distortion during the polymerization, process. But you can see where, especially back around the tuberosities, where it's, and around the peripheral borders, where it's pulled away some and the posterior palatal seal, but where it's more even in the CAD/CAM and much more even distribution of not only the fit, but the forces as well. So as Steve was saying, you are going to get, a much more intimate, fitting denture, utilizing cohesion, adhesion. And also, I think, this point, I get a lot of dentists ask me about a posterior palatal seal.
Right.
So here you think, Steve, that I think since we have this one-to-one, especially in a class 3 throat form, it's really not necessary to do a posterior palatal seal. I'd rather see the posterior palatal seal picked up physiologically in the impression than arbitrarily scribing it into the model.
I would agree completely. Yeah, these things fit. I mean, when you put one of these CAD/CAM dentures in, the patient's eyes bug, and those things just fit. They go, now that feels good. I had it happen a couple times a day, and it's because of this ability of the CAD/CAM to emulate the shape of your impression. Strength, we're going to talk about that in a bit, but these are up to twice. These are more than twice as strong as the dentures you made before, which means they're not going to crack as much. They're going to sit over an implant better. Teeth aren't going to pop out. They're much, much stronger. So Dentsply Sirona and Carbon have developed a method of printing a resin developed by Dentsply, the denture-based resin, that is looks like an old denture. This looks like the denture 199 denture, but it's really something that is you're looking at an entirely new product here. And this is what we're going to show you how to make. We call it a reference denture technique. And I'm going to walk through the 3 steps that's required. Here they are. We're going to make impressions in the patient's denture. We're going to take interocclusal records, appointment 1. We're going to have a try-in, a monolithic try-in for appointment 2. And Rob will explain how we get to that point. And then appointment 3, we're going to deliver that denture. So here we go. Oh, wait a second. I guess the other comment we should make is that you were talking about data. This is digital. Now we're not talking analog anymore. What's the advantage of data?
So in the analog world, we destroy all data all the time. We create a impression, then whether if it's alginate or VPS, usually sometimes the impression will tear, rip, and that gets destroyed when the model is created. The model has some factors you have to control for variables for distortion, and then later on the model gets destroyed as well during the processing. We have a mounting, and we do records. And the clinical records that the dentist takes for whether it be occlusion rims, gets destroyed during the setup process unless we make a duplicate set of base plates. So all this clinical data that's been acquired and gathered and acquired throughout the process gets destroyed during the analog rotation process. On the contrary, with the digital workflow, it's all saved. We acquire this data, we retain the data, and then we archive the data for future use. So if we want to later on make another denture, we have all this data, that we acquired. We can no problem, retrieve this data that's been archived and use that for another denture. And I think in the future that it will be common to have a digital file, a digital denture file updated. So whenever the denture is modified, whether it be occlusal adjustments or any type of adjustments on the intaglio surface or reline for any reason, the dentist just has to take their iOS, scan that denture, and then register the previous file and constantly updating the digital denture file.
Right.
So which will be good for any future treatment. Then you don't have to start all over with impressions.
And that, to me, it means that when the lady calls me in 2 years, she lost her denture on a cruise. We can have another one ready for them by the time they get to port.
Exactly right. You just next day air it to them, and it's
off we go. So, okay, 3 30-minute appointments. First appointment. The first thing is to decide whether we're going to use their old denture to make their new denture. This is a denture I made back in maybe the 2000s. It was a good denture, but it's seen as better days. The occlusion is worn. They like the aesthetics. The extensions are reasonable. So I look at that thing and I say, okay, I could make this denture use this denture as a guide for making a new denture. Rather than making impressions, doing a wax rim, we're going to ignore all that. We're going to use this for all that work. So number one, you've got to pick a denture that the patient has been successful with, which is going to be about 40 to 60 to 70% of the patients that walk through the door. They're going to have an old denture in hand. And then you've got to decide whether the patient would be amenable to this reference denture technique. My lady here is a very good denture wearer. The denture that she's wearing now is unesthetic. I know I can make it look a lot nicer, but she's basically worn it out, wants a new one. She's a perfect reference denture patient. If she walked in saying, I just had a denture done by your next door neighbor and it's a lousy denture, that's not the one to start with, because they'll think you just copied the old denture that was bad and make them unhappy. So you take the denture, and typically what I do is look at it and extend it a little bit. If it needs to be over on the pads like this mandibular denture or over the tuberosity, I'll add a little wax or some plastic and extend it. Now we're getting ready to make an impression in those dentures. I use this material and I love it. It's Aquasil Ultra Plus LV. Or actually Aquasil Ultra Plus system. The reason why I love it, it takes only 2.5 minutes to set, and I want things to go quickly in my office. And it has a series of viscosities that work for us. I'm going to show you 2 of them that I use. How many people use this that you see out of MicroDental? Do you see a lot of Aquasil coming through or no?
Yeah, we see quite a bit.
Yeah, I think this is really catching on, and I like it a lot. You need to paint the denture with adhesive, and this is important. Some people say you don't want to because it's kind of hard to get out, but alcohol gets it out. But we're going to scan this denture, and you want that impression to stick well and to be positioned well as you scan it. Now, I'm going to start with the material of the Aquasil Ultra Plus Rigid Fast Set. This I'm going to use for my borders. It's thicker, and it's a material that I found that was really ideal for border molding. So I'll paint my tray inside and on the cameo surface, Italio and cameo surface, because I want to catch that roll. I apply material all over the base. I put it in the patient's mouth, and I hold it in the mouth and have them go through border molding motions with my fingers in their mouth. Now, you could put the opposite denture in and have them go through border molding motions. I like to do it better by holding one end and the other, just so that any occlusal discrepancies will not show up in the impression or displace the impression. But anyway, you hold it, and you hold it for 2.5 minutes, which is quick. And this is what you end up with. Now we're starting to see a denture base that's starting to look like a denture base. The one thing that's unique here is that you see show-throughs of their denture. And unlike a well-made denture with a custom tray where you don't want to see show-throughs, on a reference denture you do, for a couple reasons. One is that you want to make sure that denture is seated down as properly and not lifted up and forward by the impression material itself, because that'll bring the teeth forward and down, which is not good, obviously, for the final product. So you want to see show-throughs, number one. Number two, you never, ever, ever want to grind on a denture you didn't make. In other words, to clear those show-throughs out, because if you grind on that denture, it's your denture now. And I've had that happen in my time where I did a little adjustment on a tooth. This is I swear the story's true. The guy comes in, he's a friend of a friend. I do a little adjustment on a tooth, come back from my lab, put it in his mouth, and he says, "Doc, what did you do? The denture doesn't fit anymore." And he shows, he points to his face as it drops down. And I ended up making him another denture for free. So don't touch anybody else's denture. I do my wash in Aquasil Ultra Plus LV fast set, again, 2.5 minute set. It's less viscous, and this is what I would end up with my typical impression. I like the impression to look kind of like the base of the denture. And this is what I want Rob to give me when I return it. But you also start to see those show throughs. Now, when you do this, you're going to actually build material on the occlusal surface, and you have to remove this. If you don't, you won't be able to occlude the opposing denture when you're making your interocclusal record. So just imagine cutting all that away with a barred Parker knife. Then I take my interocclusal record with Regisil. I like Regisil. It's a PVS that sets in a minute. There's other materials on the market that are good. This material, I like it because it's not so brittle. Some of the materials break if you flex them. This one's pretty good. So that's what I use. And this is what my record looked like. It's generous. I want to really get in there. And this is after I made the impression on the maxilla, I put these 2 dentures back in the mouth and I make my interocclusal record. And that's what I'm going to send to Rob right here. And the way I'm going to send it is 2 ways. One is I'm going to either physically send the denture to the lab if the lab's close enough to be able to scan it for me and get it back while the patient's sitting. But what we do now in our practice, and this is almost 100% now, we take a prime scan and we scan the denture on the intaglio or impression surface and on the tooth surface. We call it a 360 impression. I think they call it that way now. And you scan both sides and then scan the upper denture, lower denture, and the interocclusal record. And then you can send that data to the lab yourself and then immediately give the denture back to the patient. So I think that's appointment 1. Let's talk about the first lab.
So this was when we, I think it was about a year ago, I guess it was a year ago, last July, when they first started releasing the Lucitone Digital Print. But, it was amazing to me to actually see liquid Lucitone. And I was one that used to roll out the Lucitone and had to get all the fibers in one line.
Right.
All going this and then cut it out with a barred Parker in strips and lay it in and then put on the neck tone of the characterized Lucitone. And now to see the liquid Lucitone, it was truly, an experience. Then to hold 12 dentures in my hand, was amazing. And then go to the next slide, Steve. And then what's interesting, I did a lecture in Chicago earlier this year before the COVID. And so I asked online technicians, send me photos of your processing your dentures. And so interesting, almost all the technicians that sent me photos were of the old, compression molding using the Hanau flask, which had been around for 50, 60 years. I mean, in Swenson's textbooks in the 70s, they, show using this Hanau flask, which still probably 70% of the dentures are made in. But you look at here's 12 dentures in all these flasks in this somewhat not clean environment for processing, and all the variables that go with it, whether it be stone, the expansion of the stone, the boil out wax elimination process and possibility of teeth coming loose, the separating medium, a lot of things to control. And then here you have to the right on this build platform, 12 dentures that I was holding in my hand, so it's such a different way of thinking and a different mindset, in where we're going into the future. I mean, there's nothing, you can make a great denture. I'm not disputing using the compression molding. It's tested for, for many, many years, but going forward into the future, there are better ways, because as far as we were talking about earlier, data, this does not save any data, but on the right is where we save the data for the patient and makes it a better denture. So this is how we kind of start the process. I was fortunate to study with Dr. Frush and other people that always talked about thinking with the end in the in your mind. Think where you want to go. What is your end goal, and work your way backwards. And so this is showing the finished denture that we came up with, the Lucitone Digital Print, and with the IPN 3D Dentsply Sirona teeth. So naturally, you see a lot of things online. Steve has shown some photos. I'm always one to take the challenge, and I want to make it better. I want to try to make it more natural. I want to make it, much more aesthetic than we've seen before. So, I think this denture I would put up against pretty much any denture that you would, do, with this compression molding process or injection molding. It's a very, very, I believe, aesthetic denture. Yeah, there's things to characterize it, but I think it's aesthetic.
Yeah, when I first saw it, I called you immediately. I said, "No, this is a masterpiece right here, and this is what a digital denture can look like."
And that's just where we're starting. So with these shots are, more of an analysis, perspectives that we could never see before, perspectives that we, here we're looking, the straight lines that go to the right and left of the labial frenum on the maxillary is the mandibular ridge crests, and then the curved line going to the insides of the papilla is the maxillary ridge crest. So you can see how these lines bisect, and how they bisect in the posterior will help you also do an analysis for a crossbite relationship or occlusal scheme. And the blue lines on the mandibular ridge crest is the point of where there's more resorption on that ridge. And that's where usually the first molar goes. The brown markings on the posterior are at where the inclined plane is, where the ascending ramus starts, and more like a 22.5 degree angle where you do not want to set that second molar. So there's ways of analyzing and a denture and looking at perspectives in the digital world of the software that we could never ever do before, which really contributes to helping stabilize and making a better denture. And so this is, after the base has been built, and we do a little bit of contouring on the margins, and but yet there again you can see where the stop point is, where the brown marker is, not to to end the tooth back there. And then also you can kind of see where the red markers are the top of the retromolar pad, and then also where the hamular notch is in the tuberosity area. And then you can see the markers on this, on the teeth that represent the lip support. So if we go any further than that, then we'll be out too far into the lip support. So it shows us where our stop is for the lip support, shows us where our stop is on the ascending ramus, and then also helps us analyze the teeth to the ridge relationship. So just envision that you are setting denture teeth in wax, and you wanted to remove the wax, and then so you could visualize the tooth to ridge relationship. It's impossible. I mean, you can't do that in an analog world. You cannot just with a click of the mouse, remove the wax. But here we can, and this is why it's a better denture. It's a better denture because our ability to analyze these situations, our ability to see the teeth to ridge relationship, which contributes to improving stabilization. Just really, understanding this model analysis, I think, is in the digital world. Yes, we can analog, but we cannot see the perspectives of the tooth to ridge relationship or tooth to the lip relationships as we can in the digital world. And this software is only going to get better. This is the InLab 20 software, and which we use to design our digital dentures. And it's truly amazing how we can use this software to do this model analysis. And then, as we talked before, data it's not the people you read on social media, oh, digital dentures, they don't look terrible. They're, they're this and that. But it's not, they don't understand because the mindset hasn't changed. It's not the denture, it's the data.
Yeah.
It's the collected data that we're using that really makes it a better denture. Yes, aesthetics, as I showed you in that photo, aesthetics can be there if we understand all the variables and how to manipulate the software and use the software to make a better denture. But it's really about the clinical data. Steve goes through a lot of clinical chair time to gather this data, to record, get the impressions as he showed, to get his records, and that should be preserved. That should be, archived for future treatment. And in a digital workflow, it can be. In an analog, it gets completely destroyed. So the true differentiators, is, I believe, data acquisition and data retention. That this is what defines and helps make a better denture in the digital world.
So here's some examples.
Yeah, so this is 3Shape software utilizing denture teeth in 3Shape. So, it's important to understand the different softwares, and making these dentures, and, what are the advantages of one software, over another. And it's really, I think, ends up being the user understanding how to manipulate and use the software to make a better denture.
Right. So once Rob has designed the denture, he makes a monolithic try-in for me for appointment 2. And he uses a Lucitone Digital Try-in liquid, which is based on the tooth shade that you selected and the design that Rob came out with. So this is what a monolithic denture looks like. It's basically it's just one color denture that's printed on the carbon printer, and it represents the designs that Rob came up with. So in the second appointment, I take that and put it in the patient's mouth and start analyzing it. I look at the midline, I look at the occlusal planes, I look at the aesthetics, I get a sense of what the final denture is going to look like. Now, interestingly enough, with these reference dentures, this is basically just a nice new denture based on what the patient's been familiar with. So in my experience so far with reference dentures, they're almost universally pleased with what they see. It just looks like a fresh denture to them, but it doesn't look so foreign to them because the teeth are approximately in the same spot, with some corrections that were done by Rob. And the disadvantage is I can't move teeth. But in most cases, I've found out I don't need to, but I do need to communicate back to Rob any changes that I want to make. So I do it in 3 ways. One, I take photos of the monolithic denture in the mouth. I make notes, and then I make markings on the monolithic denture itself. So, I mean, these are typical photographs I would take. I would have a closed mouth close-up shot for him. These are going to Rob with my second prescription. I take some retractors. He can see the buccal corridors. He can see the occlusal plane, midline, aesthetics, vertical overlap, etc. He can get a sense of what we have in the mouth. Then what I do is I take a Fox plane, take Regiseal, and put that against the maxillary denture and give him a sense of what that occlusal plane is anterior, posteriorly. I also take a lateral that shows him the play between Camper's line, which is a line between the tragus and the ala of the nose. That's typically the shape of the AP position of the occlusal plane. So I send these to him, and he can make some decisions on that. I take a picture of the bite as it comes from him, and this shows where I have contacts, where I don't. And then I take notes based on what I see. This went to my local guy, Fred, but Fred, would you please modify the monolithic try-in for me? And then I make my lists. Now this list really is duplicated when I mark the try-in with a Sharpie. And this is my example here. I want him to shift the midline. On the left, I want to have him change the occlusal plane. Number 7's a little long, make it a little shorter, etc. Add a little to the resin on the cameo surface, twist a tooth. You can do all sorts of things to communicate, but I write those down. The big thing is communication. I mean, who knew that technicians wanted photographs? Basically, they usually just make a denture and that's it. With this, they're really part of it. And this is, I think every technician wished they were at the chair, but this is second best. Now, you can take that monolithic denture and send it home with the patient. And we've done that increasingly. I don't do what you see here, add a little gingival color. I send them home monolithic. But these things are real dentures, and you could actually have them test drive them. And I think sometimes it's good to send the denture home. I sent this patient home with their dentures, with their monolithic denture. Their complaint was the lower was loose. So I made a whole new impression on the monolithic denture, which will now be rescanned for the final design. Now, I guess I should have said, any adjustments you make on this monolithic denture will be duplicated in the final product. That means if you've made a little adjustment on the flange of the denture to make it feel more comfortable or not push the lip out, that's going to be duplicated. You don't have to do it again, appointment 3. So basically, you're doing all your work that will be, you typically do in the 5th appointment, you're doing it in the 2nd. So I've sent that back. And in my office, I've rescanned it. All the surfaces, the top surface, bottom surface of both dentures, and the interocclusal record, that goes back to Rob.
I just want to make one comment on the that try-in denture. So utilizing, taking impressions in the patient's existing denture, having the try-in denture is really the first time the patient's evaluating the skills of the clinician. And so they want to see, well, how well does this fit, compared to old denture. And what's really interesting is with these printed dentures, these try-in dentures, they fit just amazingly well. I mean, they have retention.
Absolutely.
Suction, they fill to the all you've instilled the confidence in this patient, and they have such a much more positive attitude towards treatment because of this already is not even finished, and it feels much better and more retentive than their existing set of dentures.
Absolutely. I had that happen today. You're 100% right. So here we have the lab side. Are they setting up the bases for printing at this point?
Correct. So those are the support bars getting ready for printing.
Okay.
And this is, of course, again, the Lucitone Digital Print going into the carbon.
Now it comes in all the colors. It's exactly the same material in your hands, although denser than the Lucitone. If you're used to Lucitone, you'll be used to this. Would you agree?
Well, that's what amazed me was their exact same colors. As I was worried, we did use Lucitone in the lab, because we had a lot of prosthodontists who would say, "Oh, I want Lucitone, light reddish pink or original," and so we were, using that in the laboratory processing. And then when Dentsply Sirona came out with this, it matched perfectly. Yeah. So if we had an old denture we wanted to go into the digital from analog, we could match it perfectly.
How long does it take them to print this many dentures?
Oh, it's about 2.5 hours.
That's stunning. Okay. Now this is the big thing. If you look at, I told you it was stronger, and this is the slide that shows that. If you look at the vertical axis, it's joules per meter square, which is a definition of fracture resistance. There's a 1500 unit on the vertical scale, anything above 1500 is considered to be a high impact resin. And all modern resins, like the Ivoclar resins, the Lucitone resins, all met that 1500 joules per meter square threshold. This new material has a quality where that by raising the temperature of it from room temperature up to body temperature, so 37 degrees C, it increases the fracture resistance by over 2. It goes up to 3,000 plus, which means these dentures have less chance of fracture. And this is a big selling point. We talked about fit, they fit great. We talk about strength. This is what we're talking about here. And this is the picture I love. And you had one that was even better, where they're squeezing this mandibular denture in an Instron machine. I mean, look at that middle picture. They've squeezed that denture so far that the flanges are almost parallel, and it didn't fracture. This stuff is like, I mean, it's as tough as nails. People drive cars over it to advertise it. It's just amazing. Oh, here's an example of one of our favorite technicians up in Connecticut. He's dropping it on his concrete floor in his lab. This is Jerry Kaiser.
The Jerry test.
Jerry test. I mean, I've seen these thrown out of windows at hotels.
Oh yeah.
This stuff is strong. And it's also accurate. Here, green shows a very intimate fit. So these dentures fit extremely well, giving us that great retention. Now, here's how they put it together. They printed the base. Why don't you talk about what there's going on here there?
So there's just a preparation of the teeth beforehand, and then we're putting, this material to fusing into the pockets. First, you really want to, make sure, clean out the pockets well, and make sure that there is not anything that's going to interrupt with the fit of the tooth in the pockets, because it's almost like a Lego-like fit, a tooth relationship to each pocket. But then they have to prepare it, for bonding. And each tooth then is placed into the pocket and prepare for bonding and fusing to the base. And then, they're like here, it's fused to the base. And then there's another process, a sealant that goes around all the gingival margins and the necks of all the teeth, and seals, make sure there's no leakage between the base and the teeth. And then there's a final curing and ready for finishing and polishing.
So this is what you're going to get appointment 3. So the third appointment, they deliver the denture to me. You've already adjusted this denture before you even had it in your hand, because you did it appointment 2. And basically you just almost hand the dentures to them. You got to make a bigger scene out of it, fitting it in. But basically all I do is put it in, put some cotton rolls between their teeth for 5 minutes just to let it settle in. Adjust the occlusion, and there needs to be a little adjustment. I like lingualized occlusion. I need to adjust this in a little bit. In centric, I don't want any contacts in the anterior teeth, which I don't have here. So, I mean, this is a lovely way to start your third appointment. Most of the time, patients are stunned by the way that it's done, happy. This is our lady we saw before. She's got a beautiful smile now. I've improved her denture, and I've done it in 3 30-minute appointments, and we're finished. That's it. That's all it takes. So maybe we could have some questions.
Questions, Medina?
Yes, I'm not going to turn on my camera because my eyes are not well, so I'm going to be very close to the screen.
Okay.
So I'll go with question 1. Obvious question is, what do you do if the existing denture isn't acceptable or they don't have a denture to use for impression making?
Okay. Well, what I do is I make impressions. I have a one appointment impression tray that I developed. So I don't do preliminary impressions. I do a final impression. It's a 4 appointment technique for me. I send I scan those impressions with my scanner, send them to Rob. He forms some occlusal bases just like we would do in dental school. I personally set teeth appointment 2 on that base. You don't have to. Appointment 3 is a full try-in, and it goes back to Rob for the final work. So it's more of a traditional technique, but I've shortened it from 5 to 4 with impression trays.
Okay. And then the next question is, can you use Omnicam for scanning?
Yes, I think a lot of people are doing that, and it works pretty well. The Prime Scan is kind of the newest evolution of that OmniScan technology. It's a Sirona product, but people are doing a lot of that with it, and it seems to be actually something that's pretty easy to do once you get a hold of it. It took us a couple scans before we got the rhythm of it, but now my dental assistants do it, or one of the dentists in my office do it, and it takes about 15 minutes to scan upper and lower.
Okay. And then the same person had an additional question. If the existing denture we are using for impression is worn down, how do we take new VDO and CR with simple bite restrictions that the doctor showed us?
Excellent question. What I typically do is I add some wax to the mandibular denture, and I try to create an approximation of the proper occlusal vertical dimension using the wax on the occlusal surface. One point to be made: if it's a lot of changes, if it's huge VDO, you don't want to do this technique. You want to do a branching technique. But if it's just a little correction, I'll either do it with that, or I'll ask Rob to open the vertical in my first prescription to them, and give them some number of between incisors. Let's say I want to increase the distance between the maxillary and mandibular incisors 2 millimeters. He can do that for me digitally, but that's where I would make those changes, either at the time of with wax or through Rob.
Okay. Next question is, what if the patient doesn't have an existing denture?
Then I go to my 4 appointment technique for me.
Okay.
The traditional analog, and then you go into digital.
Yeah. Well, I think this is a good point. I'm showing you one technique. If you wanted to use the exact technique you've always done all your life, and you want a digital denture, just ask MicroDental to transfer your final wax up into a digital denture. So you don't have to follow this technique. You can use whatever you want. The prize is that final denture for you. It might take you a little longer, but any way to get to that point's great.
Okay.
Right.
And then this question's for Robert. What design software do you prefer to use? How much control do you have over how the analysis is performed?
What just the last couple words? I didn't understand that.
It's how much control do you have over how the analysis is performed?
Oh, you had okay. As far as the design software, what I showed was in lab, and it really depends upon what we're doing. We have different solutions, digital here, MicroDental, for with this carbon workflow. I've used in lab 20 software. Yes, we have 3Shape for us, but with this workflow, I use the InLab 20. The analysis I was showing, it's all built into the software. It's just knowing how to navigate and manipulate the software to get these different screenshots of the model analysis. But it's all there built into the software. And as the software gets better and there's more updates, I mean, this wasn't available a year ago. And you're going to see in another year, I'm sure it's going to be improved even more so. So there's 100% control over this model analysis due to the software.
Okay. Let's see. Do you still have to take initial impressions and make custom trays if not using a reference denture?
I don't. I'm going to plug something for myself. Go to my website, bigjawbone, like jawbone except big.com. And I have an impression tray I've used for maybe 20 years now that's eliminated that preliminary impression. You can go straight to a final. I've got teaching videos on YouTube using Aquacil. So I don't do, I've never done a preliminary, I haven't done a preliminary impression in 20 years probably.
Okay. All right. Let's see. Next question. How much is the cost for, it just says how much is the cost? I don't know what that's in reference to. Do they send the scan via?
I think that's probably from the lab. The dentist is asking how much is it going to cost him to make this denture, probably.
Probably, yeah.
I mean, as with anything, there's variables, basic, fee is, $550, for, the type of denture we're showing, or I showed.
Yeah, they said for the denture.
There are always variables, extenuating variables. And, to do that, you first have to really understand, the case and what's involved to, give a very accurate quote.
Okay. So do you give the monolithic denture to patients with the new denture as well?
I do actually. I did that to a lady today. I give it to them for their spare denture if it fits well. Here's a typical example. I had a woman that I started a denture a week or two ago, made impressions in her denture, just like I showed here, tried the monolithic denture and didn't even touch it.
Wow.
And didn't even touch it. And so I didn't have to make any corrections. It's gone back to the lab. I'll get the final product. She said, "This thing feels so good. Can I have it?" Of course you can. So that would be a maybe a little gimme for the patient that they wouldn't expect. That doesn't cost you anything more, but it's a great spare actually.
Okay.
Great emergency denture.
I'm going to ask one last question because we're running out of time. You guys are comfortable with people emailing you directly if they didn't get their answers for the questions they submitted? Yeah. Okay.
Please, or call me.
Yep.
Yeah.
Yeah. Email,
Yeah.
our Kreyer at microdental.com, or you can call the MicroDental 800 number, 800-229-0936. Ask me, speak with customer service. We have an excellent customer service team, and more than happy to answer any of your questions, review cases, give you quotes on fees, but please call with any more questions.
Yeah.
That's a great resource.
There's one last one that I have time for. Are there other printed resins you could recommend for people who can't afford a carbon printer?
What do you think, Rob?
Well, Nextent, has, printing is coming out with some good solutions. What I would do, I would go to some different, look at what printer you do have and look what materials are validated for that printer. And so that's always very important, to understand every printer, not all materials are validated on every printer.
Right.
So whatever printer you do have in your lab, you have to find out what materials are validated.
Let's see. What was your email? Steve, I have Robert's. I'm just typing it in.
Okay. My email is Big Jawbone, just like my website, bigjawbone.com. This is bigjawbone@mac, which is mac.com.
Okay.
And I'll give you my cell phone too. It's 505-401-8200. That's my personal, that goes to my cell phone. So, if you had a question, feel free to call or, introduce yourself by email. We could, between Rob and I, we can walk you through your first case and be glad to do it.
All right. Well, thank you guys.
And if you want to,
great presentation.
More than happy to.
Yeah.
Well,
And I like that you guys are open for the questions and all that too.
Okay.
Yeah. I want to just remind everybody to make sure to fill out the CE evaluation form that will be popping up as soon as you exit Zoom. And thank you guys for joining us, and come back next time too.
Great.
Bye, guys.
That was fun.
Thank you.
Bye-bye.
Bye.